Hi, AJ Heitman here, coming to you from San Diego, from the JEMS offices, and we welcome you to our Google Hangout. With me today is Ryan Garrett, who is one of the authors for the suction article that we really put a lot of emphasis on in this month's JEMS, and we thought it'd be a good thing to get together because Ryan, the other author, Chris Brainerd, and I talked about this for probably a good year about the need for a really good suction article, and there were a lot of reasons why we thought that, but in particular, I think that the bottom line for why we did this article, which I really think is an epic article, was that there tends to be a situation now where a lot of crews neglect to bring suction to the patient side. They get dispatched to a call, and it's become a little bit of complacency where they'll respond back out to the ambulance when they find a patient with a bad airway. So I think that's the bottom line about why we did that, and we're seeing it forgotten, not just by ground crews, but also by air crews. So Ryan, why don't you introduce yourself and give us a little background, and Chris Brainerd may join us as we go along here as well.
Great, thank you, AJ. Pleasure to be here. So my name is Ryan Garrett, and I'm an EMS physician, emergency medicine physician now in Tacoma, Washington. Did all of my training in emergency medicine and then an EMS fellowship at the University of Cincinnati, and just moved out here just a few weeks ago. Started in EMS about 15 years ago as a basic EMT volunteer. Worked in a variety of different settings as an EMS provider before going to medical school, and really went to medical school to be an EMS medical director and EMS physician. So it's a pleasure to be involved with this article and with JEMS.
And like I said, I really think, and I've been with JEMS for 20 years, and I read JEMS for another, 20 years before that, and I don't remember an article in JEMS that was this focused on a particular subject. And I really think that it's important because I really see it as kind of an issue that we have to bring to the forefront. And I guess we've all talked a little bit about why we think some of this occurs and why suction is a neglected piece of equipment being taken to the patient side. So I mean, we can talk again amongst ourselves along with the audience that's out there, and if you're so inclined, you can tweet us questions and we can certainly answer those. But I guess there's a couple of postulates here that we thought about, and one was that we have so much emphasis on ALS these days that suction appears to be a BLS commodity. And then the other one is, I'll have crews tell me, well, there's so much stuff that we have to take to the patient side that we can't always carry suction in. So, Ryan, your reaction to that?
Yeah, I think it's absolutely EMS medicine, and the practice of EMS medicine is growing every day exponentially with new interventions and new treatments and new exciting ALS advanced care, and that's a fantastic thing, and that's incredibly exciting. But with that, I think it sometimes comes at a price, and we forget about the very basics. And I've said this to many of the medics I've taught around the country, that as a physician today, I have saved way more lives with the skills that I learned as an EMT basic, the basic skills, suction being one of those, than I ever have as a physician. And so, yeah, I completely agree with you, AJ. And with regards to equipment, absolutely, there's no argument that there's a lot of equipment these days, particularly first responding engines, three-man companies. Some departments around the country have two men on an engine. They're waiting for a medic unit coming from a ways away. I hear that concern as well. There's just a lot of equipment.
Well, the other one is some people will tell me that, those serious airway full suctioning cases happen very infrequently, and I have to kind of chuckle when I get that kind of argument because, the reality is we're not seeing a lot of B-fib these days either, but we don't leave the defibrillator behind, and we don't always need intraosseous. We seem to use it a lot, but we don't always use an adult IO, but if that was the rationale, we wouldn't be taking the IO gun in with it either. And, even on rescue units, the number of times that you fully have to crib a vehicle is not on every single wreck. So the reality is we still bring cribbing, and we bring cribbing out on every call. So those things really just don't hold water. And I really think, though, as we've talked, that it's perhaps because the curriculums and the textbooks and many of our instructors have not placed the proper emphasis on suctioning.
Yeah. Yeah. I think in a lot of teaching, and this is certainly was true in my EMT course 10, 15 years ago. Certainly even in my emergency medicine residency training, it's one of those skills that is just, I think, assumed. You attach it, you turn it on, and you suction whatever is in your way in the airway. And I hope the article points out that it's actually a bit more complicated, that there is more science to it, and certainly there is more importance to this skill, truly a skill, of maintaining that clear airway than is probably initially portrayed at all levels of training in healthcare.
The other one that we emphasized in both your article and my editor's page is that nobody's really um, seen us as part of the whole continuum of care, and nobody's really ever talked to us about infection and infectious endotracheal tubes. I mean, if I had a nickel for every time I saw somebody lay an endotube down on the chest of a patient at a trauma scene and then put it in the chest or introduce it and reintroduce it, never realizing that when they leave that patient at the hospital, they've left them with essentially a contaminated, dirty airway. And you see it from your side in the hospital, that we leave the EMS, whether you're an EMT or a paramedic, you never know that that patient was put on a vent and went up to the floor and ended up with ventilator-associated pneumonia or any of those things. I mean, sepsis was never emphasized in EMT or paramedic class that well to me. VAP, you can't find in any textbooks, but I know in an article that we did in a supplement not too long ago, we talked about the fact that in one hospital they said that 50% of the patients that go on a ventilator after intubation end up with some type of pneumonia infection, and 50% of those patients often die. So if somebody had told me that a long time ago, I think I would have had a whole different perspective on that. And so the reality is, and you talked in the article about people storing their suction, they rip open their sterile suction and have it connected so that they can use it. So talk a little bit about the infection that you see in the ER and in the hospital.
Yeah, so I think I am always excited to see crews and be involved with crews when I'm riding out on the trucks to get a successful pre-hospital airway. But the question that we all have to ask when we're performing intubation, whether it's in the hospital or out of the hospital, is at what cost did that intubation come at? Was there a lot of hypoxia? Was there a lot of hypotension in the immediate setting? And what cost was that intubation to the patient? And then downstream, as you pointed out, AJ, things that have kind of have been not fully explored from the pre-hospital side is what is the downstream ramifications. And so you're absolutely right. Every hospital is different in terms of their ventilator-associated pneumonia rates, but it certainly is a big problem. We know it is. We see folks that get intubated all the time for seemingly reversible or treatable causes. Let's say status epilepticus or maybe a drug overdose. And something that should typically be a very short stay on a ventilator, intubated, typically, a couple of days. But then we see their prolonged ICU stay for weeks and sometimes longer after they get these infections. And so we have to be very careful and keep an eye towards what we're doing in the pre-hospital setting. Really, truly does make a difference, and both good and bad. And so just having an eye to some of those very keen details, and that's how we advance as a practice of medicine. So we definitely see complications in every hospital. Every system is different in terms of those rates.
Do you want to talk about, you were talking about a case that you saw just 1 o'clock in the morning. I mean, I think that brings a point home if you want to mention that.
Yeah, absolutely. So I was working in the emergency department last night to work the overnight shift, and about 1 in the morning had an elderly female come in, acutely hypoxic. The first due engine company did a fantastic job, gave Solumedrol, gave the first round of Duonebs and albuterol, got her on a non-rebreather, brought her in. Her O2 sats were kind of in the low 90s. We put her on BiPAP in the emergency department, and she was looking better. I went to go see another patient in an exam room. I thought we were kind of over the cusp of her kind of acute need. She was looking much better. And then I get a frantic call on my phone that I need to go back and see this patient. And she was acutely hypoxic on BiPAP. Her sats were down in the 80s. She was actually starting to get bradycardic, which we all know is a very ominous sign associated with hypoxia. She actually was starting to drop her blood pressure. Made the decision to intubate her, and as I went to intubate her, Her mouth was relatively clean of secretions, but when I got down to her vocal cords and lifted up her epiglottis, it was just caked in with these just thick, copious secretions. And so the cause for her acute decompensation is, without question, she aspirated. And so even at 1 in the morning, having written this article and having done all the research behind it, it just reinforced with me that aspiration can occur at any time. It can occur without symptoms, as we talked about in the article, and we should never be kind of lulled asleep or lulled into complacency because a patient looks better when you're managing those tenuous airways. And so she, my suspicion is that she aspirated, and we worked quickly to rectify that and got her on the vent. She did much better, but it just was an example to me of how quickly an airway that looks stable can deteriorate. And suction is certainly a key foundation in stabilizing those airways.
And another thing that we've all talked about is the fact that we've moved and maybe progressed, if you want to call it that, to less intubation and more, get on the chest, continuous compressions, less intratracheal intubation. But with that comes even more of a paramount reason why we should have suction with us, because if we're not going to secure the airway, as most of us have with intratracheal intubation, and if we're going to be doing continuous compressions and forget about the airway, then all of a sudden we're doing good compressions, but we're allowing the patient to aspirate.
Yeah, I completely agree. I think on one spectrum, as you point out, AJ, we've moved towards less intubation emphasis for very appropriate reasons. And on the other hand, we've moved towards more advanced airway management tools, and namely video laryngoscopy. And when you look at both of those advances in pre-hospital medicine, the success of both really hinge significantly on good suctioning, good BLS airway management. The video laryngoscopy, as we talked about, is routinely overcome by copious secretions if you can't clear them. On the one hand, as you point out, if you can't manage a BLS airway with good suctioning while we're maintaining CPR, we've done a disservice as well. So absolutely in both extremes and both advancements of pre-hospital medicine.
And I think for the viewers, we have to mention that in doing this and doing photo shoots and going around developing the article with a lot of different systems, we found that people were neglecting to check their suction units at the beginning of every shift. They didn't know if they had battery power. They had units that weren't working. They had the incorrect suction tubing or connective tubing, because they simply cut off tubing at the hospital and had a much longer length of tubing to be able to elicit suction than is recommended by the manufacturers. So it's just like in the fire service, you lose pump function if you do that. And the other astonishing thing is that we found a lot of people were never taught how to check their suction unit. Even a simple test like bending the suction under pressure and seeing what happens to your gauge, people were, well, nobody ever emphasized that. So again, it goes back to, let's stay with the basics. I think you agreed, and I agreed when we were doing this, that 80% of the patients that we've ever saved is probably because of good basic life support, right?
Yeah, absolutely. No question about it.
And even with flight crews, they'll say to me, well, we didn't bring our suction because we assumed that the crew on the scene when we land was going to have suction, and all of a sudden they're 100 yards from their helicopter and the patient has esophageal varices and is bleeding out, and there's no suction available. And so all of the ALS in the world is not going to save that patient. Yeah. Isn't it kind of funny, though? We talk about, don't forget the airway bag, don't forget the airway bag. But the number one armament that's not in the airway bag is suction. I mean, I don't know what's in an airway bag other than oxygen, and that's even de-emphasized. But, I'd rather have suction than oxygen today if I was being able to take care of somebody.
Yeah, it's exactly right. It's interesting to me as we look at new bags, and certainly been involved with departments and flight programs as they kind of revamp their bags and their equipment management. It really goes to kind of an eye of professional engineering and thinking about the processes that you do on scene in terms of making sure that you have the right equipment that sets you up for success sequentially as you manage an airway. And certainly if you have a bag that doesn't include a useful tool, whatever the case may be, in the heat of the moment, you're not going to use it. And so that's something that we have to be aware of, and something that we have to overcome by other means and other plans, logistical planning. And that's an important thing.
And I will admit, I'm an old goat in EMS, and And when I went through EMT training, we actually had to disassemble, wash, and reassemble the original Laerdal suction unit, which had maybe 40 different pieces and diaphragms and everything else to it. And today, we don't have any of that. I mean, it's all a
Yeah.
closed circuit. Many of the batteries, whether it be Laerdal or Escor or whoever you're going to be using, there's lithium batteries. So in many cases, the units are so small, so portable, so easy to use. There's really no excuse.
Yeah. Yep. I agree. I agree.
And you know, the other thing that we have to talk about, people were laughing at me because when we did the photo shoot, I was showing them what I do when I train EMTs, and that is that I mix up some clam chowder and I mix it all together, mix a little tomato soup in there. I measure it to a different degree. I take a cut-off endotracheal tube, and I make them put it in their mouth and lay on the floor with the cut-off endotracheal tube in there and stay and not swallow any of that until I walk out of the classroom into another training room to get a suction unit. And then when I come back, invariably I measure what's still left in their mouth, and they've swallowed twice or three times because they couldn't stand that volume in their mouth. And the illustrated point is that, you know, a patient who's unconscious can't do that. They're going to take it all in, and some of it's going to float down into their trachea. And the funny thing was, when we were doing that photo shoot on the front lawn of one of the nurse paramedics, is that her neighbors were going by and thought there was somebody actually struggling on the front lawn being suctioned. But you know, the other thing is that people think that suction is just whatever the small French tube that they use for suctioning an endotracheal tube, and they forget that, you know, and that's why I illustrated what happens in the dentist office and what happened to me when I had some nasal surgery. You know, you got to get in there with the vacuum cleaner. You got to clear that airway out. It's critically important that you do that, especially when somebody's trapped in a wreck.
Yeah, absolutely. And I think, you know, and I encourage departments and personnel to really look around the market. I mean, when, you know, just a handful of years ago, really the only thing you had was, you know, a spaghetti sucker or a Yankauer kind of standard tonsil tip suction. And there are a lot of companies that are recognizing the problem of this. You know, I've personally used the Lipsky Super Sucker. There's the you know, the High D Big Stick. I mean, there are companies out there that are recognizing the problem, and they're providing all of us in emergency services and who manage the airway with alternative devices. There's new tubing that is of a bigger diameter. So I think, you know, one of those things of, well, I tried to use the suction on the last time and it just got clogged and there's no point. I really, you know, that really comes back to the providers and the services to look at what equipment they have, just like any other piece of equipment, and evaluate what's on the market and kind of what's best for their providers and more importantly, what's best for their patients. So there's lots of different options, you know, to kind of overcome some of these problems, you know, through a variety of different manufacturers. So.
And you've seen people at conferences where they have contests and they'll show their suction catheter versus somebody else's, and that's all you have to do with a couple of people is have it sitting there, have some Denny Moore beef stew and something else, and you try your device and I'll try mine. And you know, I mean, if I was there, I can take a shop vac and win the contest. So the reality is you got to clear the airway out. The other thing that we need to talk about is that for many EMS providers, they don't see the end result with the finances and everything else that's going on with the Affordability Care Act. And times are changing. I mean, I know that the hospitals don't tell us when we bring a patient in with an infected airway and when we cause somebody to have VAP or whatever, but one VAP case just to be diagnosed in a hospital cost the hospital $30,000. Nobody realizes that. That was one of the reasons that some hospitals agreed to fund CPAP units for crews, because they could stop a lot of intubations and stop infections from occurring. But we don't see that because there's been that door that's blocked us into the clinical side of things. I have ridden many times up in Seattle, and I was always amazed that their infection rate was so low. And when I got there, I began to realize that the medics in Seattle are heavily entrenched in Harborview Medical Center's ER all the time. So they know what infection is. They're seasoned medics who watch that. And when you go out to a call in Seattle and they're going to intubate somebody, that package isn't opened until exactly when the paramedic wants that endotracheal tube. And the firefighter that's opening that package is wearing gloves. Now, you got to look back at any other calls in your own district and say, who's opening my package, where are they putting that tube, when are they opening that, and are they treating it as a sterile field? There is a reason that the endotracheal tube says sterile on it,
Yeah.
and that's what we forgot to emphasize. And back to the other point is that we're into a situation now where future healthcare initiatives, financial reimbursement, and consequently the hospitals that are at the end result of this are going to start looking at the quality of our care versus the quantity of our care. And I don't think that some people realize that around the corner, if we bring a patient in that's not properly suctioned, they're going to come back after us because they've never cared before, but all of a sudden Obamacare and the ACA tells them that they better care, because if the patient does worse coming into their ER, who's responsible for that? It could be pre-hospital.
Yeah, absolutely. No, there's absolutely no question that the trend in healthcare is reimbursement for quality services provided, and so we already see it in the hospital. Hospitals don't get reimbursed for hospital-acquired infections, whether that's a urinary tract infection from a Foley or a central line infection. That those mandates and that precedent are already there, and we're foolish as an EMS profession and an EMS practice of medicine to think that that same trend won't extend into the pre-hospital system in the future. So there will absolutely, I think, many experts that are far smarter than I would agree that the future of EMS quality medicine there will actually be a financial incentive for quality, and there'll be a financial penalty to the fire departments, to the EMS agencies for things that we can control, and certainly, this would be one of them.
And that's kind of the good cop bad cop thing that everybody says, yeah, well, that people don't realize that that's going to come back to haunt us. There's more hospitals that are taking over EMS now that gave it up years ago because they can control the quality of the care and the customer satisfaction. But I think it's more of an issue. The issue is, for me, if my mom is laying on the floor and she's got fluid in her airway, I want that damn fluid taken out of her airway. That's the bottom line for this whole thing.
Right.
And it's even worse with kids. Kids can't naturally control their reflexes as well as we can. So suction is just so critical. Where have we gone wrong, really? Yeah.
I couldn't emphasize more. It is such a simple yet important thing for what matters most, which is the patient. And we really are just called to do the right thing in the right moment with the right equipment. We absolutely can do this. We just need to do it, and we need to take it seriously.
And I think people have said to me since the article came out, well, what kind of cases should we bring suction into? Well, what kind of cases are you bringing your airway bag into? What kind of cases are you bringing your O2? It seemed like O2 was always, at least from the time that I rode with my dad, O2 was the magic drug, and it's not the magic drug anymore. I mean, you got to have pulse oximetry now to titrate your O2, and so and most of our patients don't necessarily need that much O2, but they do need suction 9 times out of 10. And I go back to my illustration of sitting in the dentist chair. It always seems that when you're laying back in the dentist chair, at the inappropriate moment where they're drilling and they're putting fluid in there, the dentist is asking you a couple questions, and you're laying there and you're thinking, Doc, I can't answer your questions because I'm going to choke to death. And the reality is, who comes in and saves the day but the nurse or the attendant who's there? And she doesn't put some small little French catheter down in your airway. She puts some big sucker tube in about the size of a large straw, and a minute later you just feel 100% better because they've given you fluid and they've suctioned the airway out. We have to get back to the basics. That's really the important thing.
Yep, I completely agree.
And for those that are listening out there, I would, a couple of recommendations that I have, and maybe you have a couple too, Ryan, and that is that you got to go check out your suction unit. You got to find out if it works. You got to make sure that your crew tests that every day. It's a critical piece of equipment. We check our portable radios, we check our defibrillators, make sure we got batteries working, so we should have the suction unit. And we got to have something portable that goes with the patient. And I don't think it should be separate. I think that it should be somehow tied right next to or attached to the airway bag. The fact that people will say to me, well, it has to have a battery source and be on charge. And that's not always the case either. I mean, I carry a little Escort Junior, and that has a lithium battery, and that thing will last me for years. whether I use it or not. And now some of the suction units, I mean, just look at them all. They're all high quality. Impact, Laerdal, you know, there's a whole bunch of them. Escor, they're small, they're compact. There's just no excuse for it.
Right. And I think my one recommendation to add would be train like you fight. So every paramedic, every agency, every fire department at some point every year is doing some sort of airway refresher training, sign off, whether it be in the operating room, in the emergency department, in simulation. Train like you fight. And so if you're a provider, if you are a leader in your organization, if you are somebody who's involved in the training and the processes every year that go along with airway management, make sure you and your agency, your providers, are training like they fight and using the suction as part of their demonstrating their intubation techniques and their skill. Make sure that they understand the fluid nature of those suction devices, that they're actually demonstrating appropriate technique, demonstrating some of the new techniques that are coming out in social media and kind of online education, and new advances in some of those techniques. Incorporate those in the practice and train like you fight, so that 3 in the morning in somebody's bedroom, the thought that you wouldn't have the suction and it wouldn't work and that you wouldn't know how to use it is just not a reality, that it just is part of what you do every day for these critical patients. So train like you fight.
And so here's a question that somebody had asked, and yeah, I have to kind of chuckle because I did an article recently about a little child that I resuscitated that was really premature, and you know, you open up the OB kit and the first thing you reach for is the bulb suction, and it seemed like in EMT class that was the thing. As soon as the baby's born, you better have that bulb suction ready. Yeah. And so the reality is, you know, there's two funny parts to this question, and one is, if the rationale is that we don't always need suction, then, well, we very infrequently deliver babies, so why do we carry OB kits? And I always carry 2 OB kits per ambulance because we could have twins. Well, how many times do you have twins? Why do you need 2 OB kits? You have to be prepared for the worst, and for me, the worst is an unstable airway. I think that's the way you started your article.
Yes, absolutely. There is no question that if we can't maintain the airway, that everything that kind of happens after that or should happen after that really is set up for increasing difficulty, if not failure.
And, you know, in follow-up to your article, and really I think it's the kind of article that EMT instructors should be handing out to every student in class. You know, they should just make copies of it and hand it out because it's that important. But Ray Fowler has an article that's going to be in JEMS talking about the end results of bag masking are probably better from many of the studies now than they are with endotracheal intubation. So, you know, we're finding that it's not always advanced life support that's saving the patient, and in fact, if we get too much on advanced life support and forget basic life support, patients are going to slip by and go down the cracks.
I completely agree, and I look forward to seeing Dr. Fowler's article.
Yeah, and I mean, it's and I think even like your article with 20 references, that's what JEMS likes to do, is to give you all of the references that show you why infections are no good and all those other things. So for the naysayers out there, that's one of the things that I think has always gotten me as far as JEMS is concerned, is we'll back it up with those references. And Ray has co-authors and other references that are just, you know, you read it and you say, really? Bag masking is better than other rescue airways? Well, the fact is, yes, it is. And you can't argue with the experts on that. So, any parting comments that you want to make?
No, I think that this is a great discussion, and I hope folks enjoyed the article. And certainly, my email is there. And if you have any questions, please reach out to me. And I'd like to thank Chris Brainerd, who wasn't able to join us in this hangout, but it was an absolute pleasure working with him. And thank you to JEMS for letting me be a part of this project. It's certainly something I'm passionate about, and I think that it's true to JEMS' mission in terms of advancing the practice of pre-hospital medicine and the care for patients. So thank you.
Yeah, and I'm going to do a follow-up on our Facebook page and let people begin to comment, because there can be pros and cons to this, and
Absolutely.
We'll follow what your comments are, and we thank you for joining us tonight. Thank you very much, Ryan.
Absolute pleasure. Thank you, AJ, and to the entire JEMS staff.
Thanks. And this will be archived on JEMS.com, so it can be passed along to other crews or for training sessions. Thank you, and goodbye.
Great.